And hello again. Good evening, everyone. My name is Franklin, one of the two co-founders of the Northern California Spinal Cord Injury Foundation. Welcome to tonight's presentation on the use of hypnotic cognitive therapy via Zoom for chronic SCI pain. We have an outstanding speaker who's going to be taking a deep dive into research, into the research work that he's been doing for quite some time around this really important topic. So excited to get Dr. Bombardier to jump in here in a moment. But just a couple of housekeeping items as normal. Everyone has been muted, and that way we could eliminate any background distractions. There will be about a 15-minute Q&A session at the end of Dr. Bombardier's presentation. So the way that you can get those questions asked is by using the chat feature on your Zoom screen, and you can feed them to me, and I'll be sending you a reminder as we get closer to the conclusion of his presentation, and then I'll ask all those questions from him at the end of the presentation. As always, these presentations are made possible thanks to a generous grant that we received from the Christopher and Dana Reeve Foundation as part of our Virtual is a New Reality series. So we appreciate their generosity as well. And finally, we are, as always, recording this presentation in case if you need to jump off the call, or for those people unable to join us tonight. We will be sending a recording of this thing tomorrow morning. It'll be in your inboxes, and as well as we'll have it on our website for referrals. So no worries about missing out on anything. So why don't we get started? I'd like to introduce Dr. Charles Bombardier. He's a clinical psychologist and professor and head of the Rehabilitation Psychology Division in the Department of Rehabilitation Medicine at the University of Washington School of Medicine. He specializes in the rehabilitation of persons with traumatic spinal cord injuries, as well as those with traumatic brain injuries and MS. And his research focus has been on physical activity, depression, motivational interviewing, adjustment to illness and disability, and preventing alcohol problems in persons with SCI and TBI. So it is a pleasure to welcome Dr. Bombardier. Take it away, sir.
Thank you, Franklin. Thanks for inviting me. Look forward to talking with you all tonight. So what I want to talk about tonight is hypnotic cognitive therapy via Zoom for chronic pain, and woo-woo or worth a look. So that's where we're going today. Hopefully we'll have some good discussion as we go through this. So just want to start off with conflicts and caveats. There are reasons to take what I'm saying with a grain of salt. Currently, I'm leading a study on the efficacy of this approach that's funded by the Nielsen Foundation. So, I'm highly motivated for this to work. So, that, have to take into consideration that. Also, I was a therapist for most of these study participants, so I'm biased there. And it's really important to notice that the results that I'm going to talk about tonight, that from this pilot study, are preliminary, and they've not yet been vetted by a peer-reviewed journal. So that's that. And finally, I just want to humbly say that many of you on the Zoom call tonight may have severe chronic pain, and I've not experienced or lived with your pain, and I can't claim to have big solutions to help it. I can only just tell you what we're learning from our research. So I want to humbly offer that no silver bullets, but maybe something that's helpful. All right, let's see if I can move this forward. All right, so in terms of the background, why did we do this? I'm part, or have been part of a spinal cord injury model system at the University of Washington until 2016 anyway. And we would survey our stakeholders in our newsletter, and we found that pain was the most frequently listed top concern. And reader responses to our newsletter were things like, how do we deal with nerve pain? What are some natural ways to relieve pain? No drugs. Help us reduce the pain in our SCI bodies. So we've been, we've been implored to look more at this. We know from the research literature that chronic pain is highly prevalent, disabling, and difficult to treat medically in people with spinal cord injury. Treatments are available, but they rarely eliminate pain. And so there's a large unmet need for evidence-based non-pharmacological treatment options. And recent research done by my colleague, especially Mark Jensen at the University of Washington, has shown that hypnotic cognitive therapy delivered in an in-person format is a promising intervention for spinal cord injury pain. And when we started the study, Mark had not published any of his results, but since then he has published some results showing some effect on pain in disability populations. So when I came to Mark and said, gosh, if we could take this hypnotic cognitive therapy and adapt it for a telehealth platform like Zoom, and if we could produce similar effects as you can get when you do this in person, then we would have a non-pharmacological treatment approach that could be delivered to people, in much more widely than our usual approaches, and we can undergo some very large scale efficacy testing. So that's kind of the background. Next thing I want to just move on to is, oh gosh, let me just go back for a second. I'm sorry. I totally skipped over my objectives here. So I apologize. I want to emphasize why it's important to study non-pharm pain. I want to basically explain kind of a biopsychosocial model of chronic pain so that we know why these things could work. I want you to be able to describe some of the brain structures that process sensory input and determine whether you have pain. I want to explain why cognitive therapy might work or how it might help. I want you to understand how hypnosis complements cognitive therapy. I want you to know the key elements of how the study was carried out and the main results and limitations. So sorry I skipped over that. Anyway, moving on. So kind of back to like pain, the very old school model of pain that I think we still hold on to is this model by Descartes back in 1664. Basically, the notion here is that the foot touches fire, fire sends a signal up from the foot to the brain, and basically Descartes thought that there was a long fiber running from the foot to this cavity in the brain, and that then fluid would be released and makes the muscles contract so that the foot would be pulled back. So, but we have this idea of kind of a very much one-to-one relationship between pain that goes to our brain in a very, very much a direct pathway, which turns out really not to be very accurate, but he was doing his best back in 1664. Now we know that pain is really multifactorial. There's definitely a sensory component. The sensory nerves, throughout our body, transmit impulses to our brain that are kind of checking in and seeing what's happening in our body and provides information. So that's that sensory input. But we also know that there's cognitive aspects to it and affective aspects to it. And for example, a cognitive aspect of it could be if we think that the pain represents something dangerous like degenerative joint disease or a herniated disc or a torn muscle, that interpretation of the sensory input affects how we feel about it, versus if we think it's something that's more less worrisome. People have studied a lot about just kind of a more of a comprehensive biopsychosocial model of pain. We know that there's biological aspects like genetic predisposition, individualized neurochemistry, medications, immune function, your hypothalamic pituitary axis, which kind of mediates your stress response. There's also psychological factors, your experience, your learning with regard to pain, your emotions, how you think about it, attitudes about pain, memories of prior pain experiences, beliefs about pain and so forth can affect pain experience. And then also social factors, social support, your family background, how you saw people cope with pain or illness in your family, for example, even cultural traditions and the type of medical care and whether or not you're rich or poor or access to healthcare and so forth can infect a person's experience of pain. So there's many factors that can influence pain. The next thing that's very different than Descartes' view is that now, the major theories believe that all pain is produced by the brain. Pain doesn't come from the signals. It's really an interpretation of those signals. So let's take, for example, acute pain. Say you tweak your shoulder or your neck. The nerves in your body, which is kind of your body's warning system, send hundreds of signals to places all over your brain. And your brain really decides whether those signals represent some kind of danger where the body needs to protect itself. And if it meets that threshold for danger, then the body sends a signal and interprets this noxious stimuli as pain. And that causes the brain to go on high alert. It becomes very sensitized. And then gradually, if no further stimulation occurs, gradually the brain and the spinal nerves and the peripheral nerves kind of calm down and pain goes away. And that's acute pain. So chronic pain occurs if after 3 to 6 months, the brain still feels like there is something wrong. By then, the body tissues have healed, but the brain can still sense that there's some kind of danger or pain. The brain can still be on high alert. It's called kind of central sensitization sometimes, unable to calm down, continues to be on guard. And this is where pain becomes much more complex, where the activities, thoughts, beliefs, emotions, even diet can influence the persistent pain. And the goal, once pain has become complex like this and chronic, the goal is to somehow retrain the brain to wind down this alarm system. You can think of it as like a car alarm system. We know from the history of car alarms that a lot of them will go off when really nobody's trying to steal the car, but the alarm is still going off. And so we've got to figure out ways, like in our own bodies, to kind of shut off or wind down that alarm system when there is really no harm going on. The harm was done a long time ago, and now the harm is done. And so we've got to turn down the alarm system. So we can use body and mind calming exercises, physical activity, and ways to deal with stress. Some of we talk about the brain having kind of a pain matrix, and different areas of the brain, participating in that matrix. So if we look over in the lower right-hand corner, your thalamus, which is kind of your major relay station, is the part that relays the signals to the 500 different areas. And looking over to the left, the amygdala really kind of helps determine the threat value versus the safety value of the incoming stimuli. The frontal lobes kind of decide on what the pain means and begins to signal to signal or decide what to do about the pain. And then the anterior cingulate cortex determines kind of what the emotional and behavioral responses are to the signals. Is it going to be like a fear and freeze response, anxiety avoidance response, kind of a calm and coping response, is kind of what happens there. So, this all kind of implies that thoughts and our beliefs about pain matter. So when our brain has or receives positive ideas about warning signals, so, ideas of comfort, hope, or healing, that we know that this chronic pain tends to be lessened. For example, there's kind of a movement in physical therapy called motion is lotion. And then others, and other ideas, about just treatment, communicating that treatments can help. And we think that these calming messages actually trigger the brain's own analgesic responses mediated by like our own internal opioid responses, the cannabinoid, our internal cannabinoid receptors, dopamine, even oxytocin, which is more connection, or the vasopressin analgesia systems, when we get these positive, comforting messages. And then on the other hand, when our brain has or receives negative ideas about pain, like fear triggering ideas or thoughts, avoidance, dread, that pain tends to get worse. For example, if we're told that, you're going to have chronic pain, it's never going to go away, I'm not sure we can help, that those also seem to trigger physiologic responses mediated by like cholecystokinin, or maybe the opioid responses are deactivated, or cyclooxygenase activation can be implicated in the influence that negative ideas can have about pain. And all this kind of means that if treatments address the meaning of pain, emotional aspects of pain, and the degree to which we perceive threat associated with these kind of noxious input signals from our body, that if we can change those, that we can potentially impact the overall experience of pain. Another way this has kind of been, formulated into models of pain. One is called the fear avoidance model of chronic pain. And you can see here at the middle top, the injury occurs, and you can go one of two ways when you have this pain experience. You can go off to the right, which is kind of no fear. You confront the feared stimuli and you experience recovery. On the other hand, people can go over to the left and go into this kind of fear avoidance model of pain, where the person feels like there's some kind of ongoing threatening aspect of the pain. They can become fearful and can start catastrophizing about pain, which leads to kind of pain-related fear. And then that leads to avoidance behavior, which further leads to disuse of maybe the limb or the body's function. It can lead to, when we have disuse and avoidance and lack of activity, that can lead to increased disability or depression, and kind of forms this kind of negative cycle. There's quite a bit of research on that pain catastrophizing element specifically. Some research by Hugh Tink, I think, down at the bottom, some studies anyway, have looked at studies that have shown that the degree to which a person catastrophizes, so has fearful beliefs and worries about pain, it's related to people having more pain and greater disability, and that applies to people with disabilities, including people with spinal cord injury. And then furthermore, using what's called cognitive therapy, which is attempts to kind of change the fear catastrophizing thoughts. There's some evidence that we can reduce pain catastrophizing, and also the person's ability to cope with that pain. And then we know too, the other background here is that hypnosis in the past has been combined with other treatments like cognitive therapy, and there's some evidence that hypnosis can magnify the effects of cognitive and behavioral therapy. So that's why we kind of put them together. So I wanted to kind of explain what cognitive therapy is and what hypnosis is, to give you a sense of kind of what we're doing in this study. So first of all, cognitive therapy really focuses on the helpful and less helpful beliefs that we can have about pain. In cognitive therapy, what we try to do is we try to elicit and reinforce a person's theoretically or empirically helpful thinking patterns that emphasize that they feel safe, that it's pain, but it's not harm, that emphasize their sense of control over pain, like there are things I can do to manage pain. When I say theoretically, then I'm talking about kind of scientific theory. And when I'm talking about empirically, what we actually end up doing is we ask people to do like thought logs, and we ask them to tell me some of the ways that you found that are more helpful about, ways of thinking about pain, or what do you notice that you're trying to do in terms of your thinking style to kind of manage your pain. So that's the empirical part, is we ask for people's own experience. And then we elicit and invite people to also reconsider beliefs that they have that are theoretically or empirically unhelpful. So when people say there's nothing I can do to control this pain, we try to help them maybe come up with ways to dispute that idea if it is a valid if there is a valid way to dispute that idea. So maybe a person could come up with maybe it's true that the person's sometimes when they do neck stretches, they can get the pain to ease off a bit. So that really helps dispute or take the edge off this belief that there's nothing I can do to control the pain. It gives them a bit more sense of control. This kind of therapy can be pretty didactic, kind of educational and oriented, but we try to instead really, optimally, we try to personalize it and draw all this out from the person's own experience. I want to, first of all, before we talk about what hypnosis is, I'd like to talk about what it isn't, because there's been so much, most of people's experience with hypnosis is kind of stage hypnosis and so forth. So we want to kind of say what it's not. So hypnosis, first of all, is not sleep. Actually, people can be alert and awake during hypnosis. People worry that a person might get stuck in a trance, but really people undergoing hypnosis, they might delay coming out of hypnosis because they're feeling, relaxed and comfortable, not because they're unable to come out. But they, people do stay in hypnosis sometimes a little bit longer because they just feel good. Hypnosis can be used to make people do things against their will. Well, that's another myth, really. If a person's not willing to do something in real life, they're not going to do it when they're hypnotized. So it can't really cause someone to do something against their will. Also, kind of similarly, hypnotized people don't lose control over their behavior. People always have control over their behavior. They may be invited to have different experiences while they're undergoing hypnosis, but they always have a choice to respond or not respond to a given suggestion. And when we do hypnosis with people for studies like this, we are asking the person what kinds of suggestions they want us to give them. So the suggestions are actually coming from the person. Finally, there's another myth that hypnosis exploits mental weaknesses. That's not true either. Actually, hypnosis exploits mental strengths. People who are able to concentrate better, people who have a greater imaginative skills, people who can become absorbed in an experience more fully, those people probably do better with hypnosis or are more capable of using hypnosis. So what is hypnosis? It's the one quote is by Telegen is it's the ability to represent suggested events and states imaginatively and inactively in such a manner that they are experienced as real. So you're experiencing suggested events as real, and you have a capacity to make them feel real. The one by Green is the ability to respond to suggestions for changes in subjective experience, changes in perception, sensation, emotion, thought, or behavior. So again, it's the ability to respond to these suggestions, to a greater or lesser degree. And for this study, hypnosis really has two parts. One is focusing attention on the therapist's voice and on relaxing and being comfortable and feeling safe, which helps the person kind of open up their mind to the suggestions. And then the second part is receiving the suggestions for increased comfort, less attention to discomfort, and more attention to pleasant sensations. So that's kind of the two parts of this approach. So kind of more on hypnosis as we use it in this study. What we tried to do in this study is the therapist elicited what the helpful, reassuring suggestion should be from each participant. We kind of go through and talk about, what are some of the most positive ways that you found you can think about your pain, or what are some of the things that people have told you or said to you that have really helped. And then the therapist also uses the participants' ideas regarding how to counter unhelpful thinking patterns, or we help them use imagery to dampen or kind of distract them from some of the negative thought patterns. During hypnosis sessions, participants were given their suggestions for experiencing positive thoughts and experience, as well as for diminishing the negative thoughts and experiences. And furthermore, this study really focused on training people to use self-hypnosis. That is learning to get into that relaxed, receptive state on their own and giving themselves these helpful suggestions. Really, we only had 4 sessions in this study, and then otherwise people were kind of practicing it on their own, and they could give themselves their own suggestions. So the objectives of the study were to compare the effects of hypnotic cognitive therapy the way we did it, which was delivering it via Zoom, and comparing that to the results that Dr. Jensen had gotten in his study where he used it in person. And we wanted to use it in people with chronic spinal cord injury related pain. We wanted to focus on average daily pain intensity. And then we also wanted to look at some secondary effects, which is on pain interference, which is basically asking people to what extent pain interferes with their daily life. Also on depression and on measures of pain catastrophizing. So what we did is we conducted what's called an open trial, which is basically means we did not have a control group. We were just going to compare our results to the results of the other studies. And we were also just going to compare the results of our patients who went through the study from the beginning, before they received the intervention, to the end of the intervention. So anyway, we compared our results to this other study called the Power Over Pain study, which was a randomized controlled study of several different therapies, all delivered in person to people with chronic SCI-related pain. And so the other conditions were hypnotic cognitive therapy versus cognitive therapy alone versus hypnosis alone versus education alone, which is the control group. Subjects in both of the studies were community residing people in our region. The inclusion, exclusion criteria and the measures and the timing of the events were all the same in the two studies. And the interventions were manualized, and they consisted of 4 weekly hour-long sessions plus homework. So we studied people with adults with spinal cord injury who were at least 1 year out. We recruited study subjects during August 2018 to June 2019. They all had to have chronic SCI pain of at least 5 on a 0 to 10 scale. We excluded people who had, other problems or cognitive impairment, or who already had undergone hypnosis or pain. We reached out to 254 people, 54 completed eligibility, 16 weren't eligible, 28 consented, 1 withdrew, 4 dropped out. Basically 23 people, 85% of the people who started completed the trial and all the outcome assessments. So it's a small sample, 23 people. Again, our primary outcome measure was average daily pain intensity on a 0 to 10 scale. And what we do is we call people 4 times in the target week and ask them each time what their average pain is. We think that's much better than just asking people once what their average pain was for that week. That's a lot more reliable number, what you get. Then we also measured pain interference with a measure called the brief pain inventory. We measured pain catastrophizing. We measured depression, the person's global impression of change. And then we measured that. We measured these outcomes before the study began at pre-treatment baseline. We measured it at the end of treatment, which was just 4 weeks later. And then we measured it at follow-up, which was 12 weeks post their pre-treatment baseline when the study began. So we wanted to see, after treatment ended, did people get better or did they regress to where they were before? Here's what we did in the hypnotic cognitive therapy protocol. In the first session, we tried to give people suggestions for comfort and ambiguity about pain and its causes. We tried to elicit a peaceful place. We practiced the hypnosis and induction and had them go to their peaceful place. And then we asked them to fill out a thought worksheet for the next session and practice their self-hypnosis between the sessions. During the session 2, we identified positive and negative thoughts about pain. We practiced this hypnotic induction again, and we began inserting some of the reassuring thoughts that the patient said they wanted us to insert and help them believe more deeply. And then we assigned another thought worksheet and asked people to practice at home. During session 3, we did the same thing. We identified positive and negative thoughts, practiced the induction, and we practiced transforming the negative thoughts into something more positive. And then finally, the 4th session was we did an induction where a person imagines their future self in a better situation and what they learned. And then we also did kind of a maintenance and relapse prevention. All the sessions, we gave people pre and post hypnosis pain ratings. The induction included kind of breathing, scanning the body, going down an elevator or a path, and then post-hypnotic suggestions to feel comfortable, and then ways to foster practice. So, all right, so we're finally getting to the results, all right? So the Z-HCT, that's the Zoom Hypnotic Cognitive Therapy. So the group that we studied were similar to the ones that Dr. Jensen had studied in terms of age, mostly male, mostly white, 12 to 13 years post SCI. The baseline intensity scores were pretty similar, 4.8 versus 5.3. And what we did then in terms of the outcomes, we looked at, it's called a mixed effects linear regression, where we wanted to control for opioid use at each time point because that had changed a little bit in some people. So we wanted to control for that. And what we showed was that the average pain intensity in the Zoom Hypnotic Cognitive Therapy group decreased significantly by 4 weeks. So it decreased by 1.3 points, which is a pretty large effect, highly statistically significant. And then by 12 weeks, the decrease in pain was actually a little bit greater. Rather than kind of regressing to where they were at the beginning, it actually improved a bit, theoretically, because people are continuing to maybe practice some of the skills. So it went down by 1.5 points, a little bit more than the 1.3 points at the end of the treatment. We found that 26% of the participants had at least a 50% decrease in their pain at the end of therapy. And then 30% of participants had at least a 50% decrease in their pain at 12 weeks. So, there's a subgroup that's really responding quite a lot. And then, of course, there's people who aren't responding much at all. Here's kind of pictures of what we found. This shows on the left-hand two bars, at the end of treatment, 43% of patients had at least a 30% reduction. And at the 3 months, at 52% of people had at least a 30% reduction. And then over on the right, we have the 26% that had a 50% reduction in their pain at the end of treatment and 30% at 3 months. For those of you who like pictures, here's where we get to comparisons of our study, which is the Z-HCT study, with the in-person hypnotic cognitive therapy here. And you can see that our study started off with a little bit lower pain level, and it basically tracked exactly the same as the in-person hypnotic cognitive therapy study, but just a little bit lower because we probably started lower. And you can see that there is a difference. We didn't test the statistical significance, but you can see that it's substantially lower than the in-person pain education. We didn't really have the statistical power to do that comparison. It wasn't, this study was really just about, does it kind of look like it's promising enough to go ahead with a more thorough study. We also looked at nociceptive pain versus non-nociceptive pain, or neuropathic pain. Neuropathic pain on the right versus nociceptive pain or non-neuropathic pain on the left there, because we wanted to break out those two conditions to see if hypnosis would differentially affect that kind of nerve pain that people have versus nociceptive pain, which tends to be more like musculoskeletal pain and so forth. And what we found is that again, we're not doing statistical comparisons. These are just kind of eyeballing the results. But what we're finding basically is that the neuropathic pain had a pretty large decrease. At baseline to post-treatment, it decreased by 1.6 points. And from baseline to 3 months, the decrease in neuropathic pain was minus 1.7 points. We also looked at secondary results. So we looked at, did it improve other things like pain catastrophizing and depression and so forth. And I'll show you those results in a second. 91% of people who participated were satisfied or very satisfied with the intervention. The effects of Zoom hypnotic cognitive therapy versus in-person cognitive therapy were very similar. I'm just going to go over the depression. And so we can see that it has similar effects on depression. But again, our people started off with lower depression to begin with. And it had an effect on pain catastrophizing, again, with our people having less pain catastrophizing than the other group at the beginning and then later on as well, but showing the same kind of overall pattern. In terms of people's global impression of change, this is where people basically tell us from the beginning till now, how much better or worse are you? And people go from I'm much worse, I'm very much worse, I'm much worse, I'm minimally worse, there's no change, I'm minimally improved, I'm much improved, or I'm very much improved. Those are the choices. And here's what we found. Basically in terms of pain, what we found was that 34% of the subjects said that they were much improved or very much improved. In terms of their ability to self-manage pain, we found that 59% of people were much improved or very much improved. And then in terms of pain interference, we found that 35% of the subjects said that they were much improved or very much improved in terms of how much pain interfered with their daily lives. So the conclusions are this was not a randomized controlled trial. It was an open trial, and it compared Zoom hypnotic cognitive therapy to historical controls. So the results should be interpreted with caution. A fully powered randomized controlled trial is needed to determine whether this kind of Zoom approach is effective, comparing them to usual care or some kind of placebo or whatever. But with those caveats, the Zoom hypnotic cognitive therapy was associated with moderate decreases in pain intensity, 1.5 points. And we found that 52% responded by decreasing their pain by 30% or more. And the results were comparable to the in-person version of the cognitive therapy, and also comparable to other treatments like some of the medications we use to treat pain. In terms of neuropathic pain, the Zoom cognitive therapy had a pretty large effect, 1.7 point decrease in pain intensity from baseline to 3 months. In comparison, pregabalin or Lyrica results resulted in similar drops, 1.66 point drop in neuropathic pain intensity compared to baseline in one of the largest randomized controlled trials done by Diana Cardenas. And furthermore, we wondered, well, could this just be a placebo effect? But we looked at research on placebo responses to neuropathic pain and found that basically placebo responses in people with neuropathic pain are very rare and small. The average change when given a placebo, if you have neuropathic pain, is only about a half a point, 0.6 points. And fewer than 10% of placebo subjects experience at least a 30% reduction in pain. So we're thinking, again, this is somewhat speculative, but we're thinking that, what we're seeing here isn't just consistent with a placebo response. Right, that's the end of my talk, and I'm ending with, a advertisement for our study. This is the study where we're doing a randomized controlled trial. People can get this intervention. They have a 50% chance of getting this intervention versus a waitlist control. So this is the study where we're trying to see more definitively whether this intervention is effective. All right, so I'm going to stop my share, and that's
Great.
it.
Thanks so
Happy
much,
to
Chuck.
talk about this.
Indeed. So obviously you answered one of the questions, which is how do we sign up for the study? You mentioned obviously only 50% of the people are going to get into it. Is there a plan to enroll them in the actual study or give them the treatment upon the conclusion of the study?
Really good question. And I like to design studies where I have the capacity to give everybody the intervention eventually, but that ends up almost doubling my costs. And so I didn't have enough money to do that. So unfortunately, I don't have the capacity to provide people who in this control group with the intervention. So
Okay.
sorry.
All right, no, not a problem. How many people are you planning on enrolling in this controlled study?
We're trying to get 160 people, and we have about 103 so far.
All right, outstanding. One of the questions is diagnosis of depression is sort of oftentimes goes underreported or just not reported, period.
Yeah.
How does that obviously has some level of interference with the brain's sort of function and responsiveness to hypnotic therapy, wouldn't it? And how do you account for that?
Really good question. And you're absolutely right. I mean, depression seems to magnify the experience of pain and suffering in people with all kinds of pain disorders. We are not excluding people who are depressed from this study, but we are measuring depression. And so we should be able to kind of tell whether or not the presence or absence of depression influences how well a person responds. We should be able to kind of tell whether or not this intervention has a positive impact or a negative impact on depression as well, whether it has a kind of a spread effect. So it should tell us some things about the interaction between those two conditions. but right now, we really don't know whether or not how depression might interact with the treatment.
Okay. All right. Next question from this person. It seems I'm always changing my approaches. Do I need to eliminate other methodologies, including meditating, for example?
Oh, interesting. So people do use meditation sometimes to manage pain, but it sounds like this person is saying that they keep changing. I don't think there's anything wrong with changing. I think that meditation could have a positive effect. Um, but from my reading of the literature, I think that something like hypnosis and cognitive therapy may have a greater effect, because meditation is basically largely kind of calming down. Oh, it is. I mean, it's calming down the body, and it's also calming down the mind, and also maybe has a distractive element to it. So I think it could have a positive effect. I'm not aware of any studies in spinal cord injury showing that meditation, though, has a significant positive effect in that we can see across groups. But I think it's a very reasonable approach to take, and that it benefits some people greatly.
Okay. Next question. How about traumatic brain injury? Is this a study that also looks at that?
We are excluding people that have more severe traumatic brain injury because we did not want to, we thought that it would require quite a bit of maybe cognitive functioning and attention and so forth. And so we were concerned about having people with more severe brain injury in it. I think that we still include people with more mild brain injury, but definitely having more severe cognitive impairment could interfere with a person's ability to participate. And that said, a lot of times when we do these studies first, we kind of try to cherry pick people that we think have the most promising, are going to have the most promising response. And then if we get a positive response, then we try to expand and see if a larger group of people that are more diverse can also benefit. So I think if this turned out to be beneficial, the next studies we should do is to try it with a broader range of people, including people who have comorbid traumatic brain injury. But we're not there yet. We try to take an easy way out first to see if it has any effect, and then we go broader.
So this, the question was more of, I guess someone has both spinal cord injury and
Yeah.
TBI as well.
Yeah, that's what I meant. I mean, so we're kind of excluding people with more severe traumatic brain injury, and of course, they have a spinal cord injury as well. But if they also have comorbid brain injury and it's pretty severe, we're not letting them into this study. And in the future, we would allow people in possibly that have more of a traumatic brain injury. But right now, we're kind of cherry picking people that might have we don't know if we don't know if brain injury will interfere with a person's ability to benefit, actually, but we're just being exclusive right now.
Okay. Fair enough. At the beginning of your presentation, you mentioned that the idea is to basically sort of tell the brain to sort of calm down and not think that there's danger.
Mm-hmm.
What if there is danger, and then this therapy is telling the brain, kind of ignore it. There's nothing going on there. Is that a possible kind of danger, I guess, to the use of hypnosis or hypnotic cognitive therapy to deal with pain management, when it might mask real pain or real trauma that's taking place somewhere within your body, and due to lack of sensation, etc., you're not able to differentiate between real trauma and phantom, trauma.
Super important point. Really, really important point. And so we take pains to make sure that the type of pain that people have is chronic pain. It's not new pain. When we do the intervention, we basically ask people, do you feel comfortable kind of allowing your brain to sort of not pay much attention to this pain, because that's where we're headed. And is that going to be safe for you? So we kind of take a variety of precautions in terms of the kind of pain we select, whether the person, whether it's an old pain, it's not something new, it's not something that has meaning for the person in terms of safety. So we're kind of just careful about selecting that pain and making sure in several different ways that that it's safe for the person to not pay as much attention to that pain. But you're absolutely right. And actually we give suggestions. Part of and I don't want to go into too much detail here, but part of one of our sessions, maybe more than one, when we give people suggestions, we tell people that they will find themselves, allowing certain sensations to drift to the back of their mind and not really respond to them. But any new sensations, that they will continue to attend to those and take necessary action. So even in our suggestions, we always weave in this notion that if it's something that seems different or new or worrisome, that they should continue to attend to those pains.
Okay. So, well, let me ask you a follow-up question. I often hear from people who, when I ask them where the pain is, they say all over.
Mm-hmm.
So how do you, when you have pain all over your body, how do you identify a new pain? Because you just sort of lump it with every pain throughout your body. So how would you be able to identify that there is something new that I might need to take a little bit more seriously?
Yeah, that's a really good point. And I don't have a good answer for that, except we are relying on people's ability to perceive new symptoms. And it may be, it's a good point. We may be possibly over relying on their ability to distinguish new warning signs. I
Yeah,
don't know.
well, anyhow, okay,
Yeah.
next question. This question comes from a nurse practitioner.
Mhm.
She says, I want to help my patients who have neuropathic pain, and I often furnish pregabalin and gabapentin. Until I can find a cognitive hypnotic pain program for my patients, what are more helpful and less helpful ways to talk with my patients about pain and neuropathic pain? For example, today I asked about whether my patient had a retained bullet. Then I worried that the suggestion of the bullet and its relationship to pain was not very helpful.
Oh man, you're bringing up one of the most difficult things I've ever faced too. Similarly, with patients who have a retained bullet, they have trouble. That's a tough thing. That is a really tough thing. I don't have a good answer for that. I don't have I mean, um, I don't have, in my study of psychological approaches to managing pain is that there aren't any that have shown any efficacy so far. So I don't have good answers for you because I think the science is that we don't have good answers. This is the strategy that I think has had the most promise of anything I've read. So and I don't know how to reassure people that have retained bullets either. And I found that very difficult in the past working with physicians and nurse practitioners to try to reassure people when they think that that might still be harming them. I think that's been I've experienced that as being very difficult
Okay,
to reassure people.
very good. So the next question is this phase of your study is obviously a much larger sort of group that you're seeking to enroll. So is it, it's basically a new study because it's now a controlled group, right?
Yeah, this is controlled.
Right,
Yeah.
okay. All right, this person had tried for one recently. Should people try again for, if they had tried for your first, study and did not get in, should they try for this one as well, or?
Yes, if they tried for the first study and didn't get in, that they could have, I don't know why they couldn't get in. And some reasons, I can't really reveal all the reasons why people can't get in. But if they couldn't get in for reasons that may have changed, for example, for example, people have to be on stable doses of pain medications, for example, I can say that one. And perhaps the person didn't get in because their medications were very unstable. Maybe now their medications are stable and then they would be eligible. So yes, I would try again and see if you're eligible.
Okay. And speaking of medication, so I'm sure you tell the patients or the enrollees that they should continue with their current sort of regimen of medications, right?
We do, yeah.
Yeah.
And of course,
Regardless of how much improvement they might see.
yes, we tell them that, but of course they're free to do what they want. And so we do have patients who or participants who change their medications up and have less or more or change. We can't control that, but we do ask people to try to keep a steady, stable dose.
Okay.
But yeah.
All right. Next question. This gentleman says he took part in a similar study at Washington University. As far as you know, this is the only one, like the one that you conducted, and then this one that you're conducting right now, right?
Yes, I'm at the University of Washington, but
Right.
not Washington University.
Oh, okay. There's two different ones.
Which is in
Okay.
St. Louis. Wash U is in St. Louis.
St. Louis, yeah.
But we are recruiting throughout the country. So it could be that this is the study that they heard about at Wash U because maybe we have people there who are telling people about it. So
yeah, all right, good. So the gentleman says that he did find it beneficial, but then he backed off the self-hypnosis sort of portion of it.
Okay, yeah.
Okay, next question. How much time daily does a homework assignment take up?
Okay, so we ask people to listen to the recording daily if they can. We make a recording of the session, and so that would take 20 minutes. And then we ask people to do kind of a brief practice where they, we give them like a 1 or 2 or 3 minute kind of practice, and we ask them to do that several times a day. Most people don't do it that much, and they still get a pretty good effect. But that's what we ask people to do.
Very good. As a researcher, what is your hope in terms of the longevity of this form of treatment? Is it something that people are just going to have to continue doing throughout their life in order to kind of retain the reduction in pain that they experienced?
Super good question. And again, that's one of those things where we don't know. We are getting kind of short-term outcomes 3 months after the end of after they start, usually 6 to 12 weeks or 10 weeks after maybe they ended treatment. But we don't know what the longer term effects are. So we would have to do, we would have to do kind of next study would be how long do the effects last? But there are definitely some people who have said that the effects seem to be long lasting, which it's a really good sign for us to see that the effects at the end of treatment were less than the effects at 3 months. Because, maybe what we can do is maybe the brain can learn and just become more automatically less freaked out or, worried about or interpreting as dangerous that pain. We're thinking that the results could be long lasting. That's what our hope is, but it's an empirical question.
Okay. Do you envision a point where you could, again, a reduction of 1.3 to 1.6 grades in pain are outstanding, but do you envision through some other form of hypnotic cognitive therapy for that decrease to be even more significant? For example, if I have on a scale of 0 to 10 experiencing 9 consistently, 1.6 would be great, but 5 would be even better. What's your expectation in terms of the deeper impact of HCT?
Right now I'm not sure if we can. Dr. Jensen is looking at very various combinations of treatment. He's trying to combine hypnosis with brainwave training or other things that are, again, a little more woo-woo too. But I don't know. This is kind of new territory, and I don't have a good sense of what else we would do to enhance the therapy. Maybe more practice, maybe additional therapies that get at other angles, but I don't have good ideas about combined therapies right now or how to get it down further, and certainly recognize that this is could be a very small effect for people and that they have a lot of residual pain.
Right. Well, you're certainly at the cusp of something great. So I think through further study, you'll hopefully we'll figure out how to amplify the effect that you're placing on the brain's capacity to recognize pain. Okay, next question. Have you heard of the Curable app for chronic pain? If yes, does this app therapy work the same as hypnosis and cognitive therapy? And would doing this app disqualify a person from the trial? If you haven't heard of the Curable app, then
I haven't heard of it.
you won't be able to answer this
No.
question. All right. And everyone, in the email that I'll send tomorrow morning with the link to the recording of this, I will provide information about how to apply to enroll in the study. So no worries, Dr. Bombardier, you just send me probably that last page of your presentation that has all the information on people to enroll. All right, so the next question. I am in the study. I'm just in the control group that doesn't get the therapy.
Sorry.
Anything else to suggest?
No, I don't. We'll try to publish, we'll try to get the results and publish them as soon as we can. And if it turns out to be helpful, then hopefully we can, if again, it's a lot of ifs, right? But if it is helpful, I'm hoping that we can begin training people on how to do it. You know, we've got it manualized, and it should be fairly easy for people to learn to do it. I learned to do it. So I'm hoping that in the next couple of years, I'm sorry, it still seems like a long time, that we can, you know, try to make it more available to people to learn and disseminate the results. So.
Okay, fair enough. I think that's the last question. Motivated by your talk today, I want to go online and perhaps find a video talking about self-hypnosis. Do you have any websites or videos that you recommend as a starting point at this time? Just to give some familiarity on this topic.
I don't, and you know, and if you want to participate in our study, I'd advise you not to do it. I think I really believe that the hypnosis has to be tailored to you. If you go online and listen to some recording that's been made, it's not tailored to you. And I think that the important aspect is this is very highly tailored to the person, their own beliefs, where their beliefs are not helpful, where their beliefs are helpful, and we are, you know, working with them on this very, you know, individual basis to tailor it for their particular mind. So I'm doubtful that online approaches are going to help because they're going to be very generic, right?
Yeah.
And I think it's the tailoring that really makes a difference.
Okay. All right. One last question snuck in. How did this idea originate by Dr. Jensen is the one that initially thought of using HCT for pain management in the spinal cord injury population? How did this even begin to sort of shape?
Yeah, well, I mean, back in, I think 1998, a paper by, gosh, now I'm blocking his name. You know, there's a meta-analysis that suggested that hypnosis kind of played well and amplified cognitive behavioral therapy, which is a common approach to pain. So, you know, back in the 90s, there was beginning evidence that hypnosis might amplify. And then, yes, Dr. Jensen was the one who started kind of examining that in people with disabilities, especially spinal cord injury and MS. So he's really, I mean, Dr. Jensen has like 500 publications in pain, and he's like a genius in treating pain. And I'm just in the office next to his, and I had experience
location, as realtors say, right?
I had experience in doing teletherapies and rehab, tele-rehab, and that was my expertise. So yeah, he's been really the creative genius behind this. But it still goes back many years in terms of people having this idea that they could be combined. So
very good.
Yeah.
Okay, that's all the questions. Thank you so much, Dr. Bombardier, for taking the time out of your evening to inform us and educate us about this. Again, everyone, we will be sending a recording of this session. It'll be in your inboxes tomorrow morning, and Dr. Bombardier is going to send me the slide that has all the enrollment information for those of you that sent several questions asking for how to get into the study. And it sounds like there was still some room for additional volunteers, Dr. Bombardier. So
yep.
great to hear that. Thanks so much again for your time. Really appreciate you investing your time to deliver this news and information. Thank you everyone for taking part in this presentation. We hope you enjoyed it and have a good evening.
Good night. Thank you for inviting me. Bye-bye.
Okay, take care.